Welcome to Eyes Wide Open, a podcast aiming a curious eye at what's new in eye care. This podcast is a service provided by Canadian Eye Care Business Review. Please visit their website at eyecarebusinessreview.ca to stay up to date with the latest eye care news and lots of great resources and articles. I'm your host, Glen. I'm an optometrist practicing in Toronto, Ontario, and I love to learn new things, and we're going to use this trait to investigate what's new in eye care in the vast array of areas that eye care providers are lucky enough to work in every day that we're in our offices. So let's take a look. Today I'm going to be speaking with Dr. Jeff Goodhew. Dr. Goodhew is a practitioner in Abbey Eye Care, a full-scope independent practice located in Oakville, Ontario. Along with his spouse and partner, Dr. Tina Goodhew, they have opened practices in 3 different provinces. These practices varied in modality from private practice to corporate settings. He enjoys seeing all patients in a primary eye care setting, but has developed several niche offerings, including myopia control, glaucoma management, and dry eye therapy. Jeff is also very involved in the optometry profession. He currently sits on the board of directors of the Ontario Association of Optometrists and served as president from 2014 to 2016. Along with his spouse, Dr. Tina Goodhew, they are the co-founding editors of Canadian Eye Care Business Review. All right, so I'm here with Jeff Goodhew, an optometrist in Oakville, Ontario, and we're going to be talking today a little bit about ZEISS lenses and their lenses specifically for myopia control, myopia management. So Jeff, we're going to start off by assuming that obviously as an optometrist, I know about myopia and more patients are becoming myopic. I'm aware of some of the ocular health issues potentially associated with high myopia. And we're also going to assume that I'm a little bit aware of myopia management in its various forms. So we're going to look more specifically today at what ZEISS is bringing to the table to help our patients. So I'll get you to give me a brief overview of the myopia prevalence and sort of the trends that way.
Thanks, Glenn. And thanks for having me on your podcast. And maybe I'd like to start with a quick story if that's okay with you.
Please do.
I don't know if your listeners know this, but I think you and your colleague, Peter Rosnick, had the very first podcast in the optometry space, either the first or at least the second. Do you remember what year that was that you started that podcast?
No idea. I'd say probably 10 years ago, maybe.
Yeah, I'm thinking 2007, 2008.
Yeah.
So back in the day, I had a flip phone, and so did everybody else. I had to listen to your podcast actually on an iPod, hence the name. Whereas now I can listen to podcasts on any device I want. So podcasting is a big thing. There's probably 15 optometry podcasts, but kudos to you. I think you guys had the very first one. So nice to see you back in the saddle again.
Yeah, well, thanks. It was a fun experiment. And then it just got to be we did all our own research and pulling up stories, and it got to be a lot of work, but it was a lot of fun. So thank you. Thank you for that.
Cool. So back to your first question. So I guess maybe we'll start with myopia prevalence. And I'm going to sort of lean on the Brian Holden Institute, which is sort of becoming sort of the global thought leader in this space. But they project that by 2050, half the world's population will be myopic. So between, let's say, 2020 to 2050, you're going to see an increase in prevalence about 1% per year. So that's going to keep us busy in our practices. It's going to allow us to help some of these patients because it's becoming a bigger and bigger issue.
Right.
And as far as eye health goes, like you touched on before, you know the risks, increased risk of cataract, particularly, posterior subcap, glaucoma, RD, myopic macular degeneration. These are real things. And I had a patient, 50-year-old patient, -7, comes in, rapid blur over the last couple months. Turns out he's got a posterior subcap cataract. No problem. Send him off to the cataract surgeon. Gets that done. A year ago, he comes back with a MAC-off detachment. So I'm thinking, you know what? He's -7. If I were to see him as an 8-year-old and implemented some of these myopia control options that we now have, maybe he wouldn't have had the PSC. Maybe he wouldn't have had the RD. These are real impacts we can potentially have on our patients.
For sure. And it's unfortunately, I do have several patients with myopic macular degeneration, and it's devastating enough in a senior with AMD. It's particularly debilitating in a younger patient who's still active and working full time and suffering some vision loss. So yeah, being able to help these patients out, definitely something we want to have in our arsenal, at least to minimize their myopia.
Yeah, so I think it's changing our mindset around myopia, not just a refractive error that we're changing the child's prescription year after year after year. Rather, myopia is a disease, and its progression has impacts on the future eye health of our patients.
So you and I as optometrists, what can we do? What do you see our role being?
Educating our patients, educating our parents and young myopes, that telling mom and dad that, hey, when you were a child, we just gave you new glasses every single year. With your son or daughter, we have tools in the toolbox now that can help slow down or modulate your child's prescription change, and not think of glasses simply as just a fix for the refractive error, get them to see 20/20, but more as a therapeutic option. So before we get too far into what the ZEISS lenses specifically, what is ZEISS's role in sort of raising patient awareness about myopia and myopia management? So ZEISS has been in this space for probably over 20 years now. They came out with their first myopia control lens in 2007, and it was a 10-year lead up to that point before they launched that lens. So they've been in this space kind of in Australasia, that part of the world for 20 plus years. So yeah, they know this space, and they've helped, that they provide materials in our practice as far as pamphlets, explainer videos that I can put on my digital signage. They haven't done any sort of direct to consumer marketing. I don't think any company's really done that yet, because the consumer out there doesn't know about myopia control. We know it, you and I know it, but the consumers don't. But there's a lot of great tools that I can utilize in my practice from ZEISS. And I think it's because they've got 20 plus years experience in this space. So let's dig in a little deeper into their actual lenses. So from my reading, their main two lenses, the ZEISS MyoVision Pro and the MyoKids, correct? Yes. So the MyoVision Pro, so that's the new and improved version of the original ZEISS MyoVision, which came out in 2007. So it's sort of their free-form design of that lens. The MyoVision and the MyoVision Pro utilizes peripheral defocus, similar to what, say like the MySight contact lens would do, or what Ortho-K does. So by creating peripheral defocus, you're shifting that focal plane from behind the retina. So move it in front of the retina. So we call that myopic defocus. And that seems to be a pretty strong signal to the retina, to the back of the eye, not to grow so quickly. So the way to be more specific on the MyoVision Pro side, the center 15 millimeters of the lens is the prescription. So if your child's -3, the center 15 millimeters is going to be -3. And then that relative plus starts beyond that. So at about 20 millimeters, you're looking at about a 1.5 diopter add, and then at 25 millimeters, 3 diopters of add. So that creates that myopic defocus.
Right. And the rationale there being for the retina to not want to grow backwards, essentially.
Yeah, I mean,
because of that peripheral blur.
Exactly. So the researchers are basically starting to tell us that there are cells in the mid-periphery of the retina that can detect the direction of the blur. So whether it's in front of the retina or behind the retina. If it's behind the retina, the eye will tend to lengthen. If it's in front of the retina, the eye will tend to slow down. So that's even with the optic nerve severed. So this eye growth is controlled, we think, within the cells of the retina, not necessarily, further down in the visual pathway. So creating myopic defocus, I think, is a real key.
And so tell me a little bit about the MyoKids and that lens design.
So the MyoKids is their new lens, and that it's like a progressive addition lens. It's like a PAL, but it has some special features to it. So it's based on the accommodative lag theory. So Kate Gifford, who is an Australian OD, again, very erudite in the myopia control space. Her website, I think, is myopiaprofile.org. What she's saying is that there seems to be an association between sort of high levels of esophorio and accommodative lag in myopic children compared to, say emmetropes. So there are some kids out there who have a high accommodative lag, who are ESO, where this MyoKids lens seems to work quite well. And it's not simply a traditional PAL where you've got like a 150 add at the bottom or a 2 add at the bottom. It has, just outside of the add zone, Glen, it's got some sort of relative negative power, which seems to drive the accommodative response, bringing everything forward. So bringing that accommodative lag forward. So studies have shown that the MyoKids lens reduces accommodative lag by about 30% more than a traditional, bifocal or PAL. So it is specific to reducing accommodative lag.
Right. So this isn't just a quote unquote traditional progressive lens that's been co-opted into a myopic lens. This is a different design entirely.
That's right. So it has your traditional ad zone, and you can customize what that ad zone is anywhere from +1 to +2.5. But just outside of the ad zone is that relative negative power to help drive. So that relative negative power lands just outside of the fovea. And that seems to be a stimulus to drive the accommodation. And when you do that, you're bringing everything forward. You're reducing that accommodative lag.
Nice. And so they have presumably 12-ish years of data surrounding this.
Yes.
I'm assuming. And any numbers in terms of reduction of myopia over time?
So there's lots of papers out there. And I think at the moment, most of the published data in myopia control is around spectacle lenses. And the numbers range from 10% to 50%. There's just massive swings in data, depending on the ethnicity, the children chosen, how quickly they were changing before they got into the study. So the numbers are all over the place, but the ZEISS lenses seem to slow down myopia progression by about 30%. And that's kind of what I tell my patients. Spectacle lenses and myopia control seem to provide about 30% control of their myopia.
Nice. And so, a good segue into what I wanted to talk about next, which was sort of how do you have that discussion about myopia management with the patient and their parent? Because again, I'm imagining a lot of them, like you said, are, hey, I got glasses when I was 10, I got new glasses when I was 11, and I got new glasses when I was 12, and it just kept going from there. How do you bring this topic up with the patient and their folks?
Yeah, that's a great question. That's something we've struggled with when we implemented myopia control in our practice a couple of years ago, was having those conversations with parents. I mean, parents don't even know what myopia is. So don't even think they know about what myopia control is. So this is all brand new to them. So to tell them, okay, we've got this toolbox. We can control your child's myopia from getting worse. There's essentially 4 different options: glasses, contacts, drops. Contacts, soft and hard, and then drops.
Right.
So again, the whole topic of myopia control is brand new. All of these therapies are new to the patient. So you're dumping a lot of information on the parents. So you really have to think about how you're going to deliver that. And we do, in Ontario, given the OHIP reality, we do child exams in 15 minutes.
Right.
I'm sure you do something similar. The myopia control,
16 minutes.
16. You're just a bit slower than I am. Okay.
That's right. Fair enough.
So I could spend 15 minutes doing my regular child exam. I could spend the next 15 to 20 talking about myopia control with the parent. And that's right. What we did initially. We see a lot of kids in our practice. So very quickly we would run behind in our day. We see lots of kids. You're thinking, oh my gosh, the next kid's myopic. I got to have this conversation again. And then you don't have it because now you're running behind.
Right.
So we've kind of boiled it down into, say, 3 or 4 minutes. And then we hand our patients over to a staff member who is knowledgeable in this space. And to make your staff knowledgeable, just have them in the exam room for, say, 10 of these conversations. And then they understand the messaging that you're trying to get across. So they can go out of my room, they can talk to my staff, ask all the questions that they want. And then we email them a document, a PDF document that has all of the 4 different options that we provide. And by emailing them, that opens up another channel
right.
for them to ask questions.
Nice.
And what I find is, usually after about, say, 4 to 6 weeks, parents will get back to us by email or phone and say, hey, I've had a chance to review this. I think I'd like to go ahead with therapy A or therapy B. It's pretty rare that you get a parent come in, child goes from -1 to -2. Okay, let's go do topos and we're going to do ortho-K. That does not happen. It's a long, I hate to use the word sale. It's a long sales cycle.
Yeah.
But eventually they come around. But what you've done is you've planted the seed. You've told them that we can control their myopia. And for fast progressives, I'll check them back in 6 months. And oftentimes that's when the parent will say, hey, you know what? I had a chance to think about what you told me. I'd like to pursue one of these options. So don't expect your parents to convert, because they want to go home and research. They want to go on Google, talk to their friends, get more opinions. So just come up with a process in your office. Otherwise, these conversations are going to bog you down. You'll have one, during the course of your day, you'll run behind and you won't have another one.
Right. And I mean, I'm imagining just, as a parent and as a eye care provider, I would imagine that spectacle lenses would sort of be an easier transition if you're thinking myopia management at all. Moving from glasses to, myovision glasses seems like a pretty easy lateral move, right?
Yeah, I would agree with you 100%. That's the most, I guess, sort of benign therapeutic tool we have in our toolbox. So adoption with that is pretty seamless with parents. And again, I give them all the control rates with all the different tools, and I tell them spectacles typically 30%, but it's not a big upgrade in price to move into one of these myopia control lenses. So yeah, a lot of our parents do proceed with spectacle lens therapy.
So sort of along that same line then, if we're assuming this is a patient maybe who's too young for contact lenses or just does not like to wear contact lenses, in terms of patient selection, do you have a sweet spot in terms of age of the patient that you're looking for these lenses?
So age, because it's not a contact lens, so I think the youngest patient we fit in this would be age 5 or 6. Those kids who went from, plano to -1 in the course of a year, and parents are highly myopic. As far as the prescription range goes, the nice thing about these lenses, I don't have the exact parameters in front of me, but they go well north of -10, lots of astigmatism, different indexes, photochromic. So unlike, my sight contact lenses or Ortho-K, which have prescription limitations,
right? With
spectacle lenses, there's virtually no limit. So we can fit any child who wants this spectacle therapy. We can pretty much accommodate them. And
then is there sort of an idea that they've sort of grown out of this lens at some point age-wise?
Again, myopia control is fairly new in our practice. We've been doing it for, I guess we're in our fourth year anniversary this month. For me, again, you really, around age 16 or so, when myopia naturally slows down, kids get their driving license. That's kind of when I have the conversation. Okay, maybe we can put you back in traditional glasses and or contact lenses, but also monitor them. Keep that 6-month visit schedule in place and track and see if their prescription starts to scoot up again. If it does, you can implement it again. But, I like to sort of stop treatment, watch and see what happens, and don't hesitate to start it again if you need to.
And would you say that's a sort of your default protocol for monitoring these patients? Maybe, twice a year as opposed to just your once a year annual exam?
Oh, for sure. Yeah. Because we want to monitor refraction. Obviously, we're fortunate to have an IOL master, so we track axial length, which is, you don't need that for myopia management, Glen, but it's a nice to have.
Sure.
So yeah, I mean, it's nice. And just to have those conversations with parents every 6 months to say, hey, our job here is to control. We can't stop. We always reinforce that we cannot stop your child's prescription from getting worse. We can only slow it down. The numbers I'm giving you are average. Some kids, the myopia tools do nothing. Other kids, it stops them dead in their tracks.
Right.
So that way, if the prescription does change, the parents are like, yeah, you told me that, this was not 100% guaranteed. Are there other things we can do?
Right. And for the most part, parents have been happy with your results?
Yeah, no, they have been. They have been. So I'd be hard pressed to find a child patient that we've seen where the myopia continued to progress at the same rate or slope prior to initiating therapy. So, again, we've had some where the control has been low. We've had some where they haven't changed in 3 or 4 years.
And do you have sort of a benchmark of what you would consider, quote unquote, success with this therapy?
So
I guess it's so individual, it might be hard, but what would your sort of gut feeling on that be?
Yeah. So when we put patients into our myopia control practice or protocol, we've got a special exam form that we enter sort of the rate of change, how quickly they were changing. Was it a diopter a year as they entered our clinic? And then after, so if they're going up, $1 a year, -1, and we change them to -50, that's success.
Right.
If it's half diopter a year and they're changing by a quarter, that's success. So it's all based on how quickly they were changing before.
Nice. And I'm assuming you had that conversation with the parents and the patients subsequently as well.
Yes, every visit. So if you do get that kid who all of a sudden accelerates all of a sudden, the parents aren't surprised.
Right.
they'll say, hey, yeah, you did tell me that this could happen.
Yeah, I think that's one of the important takeaways of this is that there's likely going to be progression. We're slowing the rate of that progression.
Yes.
Right.
Yeah.
And I think parents might get the impression that it's, this is you're going to be -2 forever. Right.
No. Maybe you'll end up -4, but you won't end up -7.
Right. And then, so, you mentioned already some of the things that ZEISS can provide. So if you talk to your ZEISS rep, I'm imagining they can give you some POP material to help with that discussion.
Yeah.
And so, given all of these tools and our knowledge of myopia and what we can do to try to slow it down, what's one reason you think why people would fail with myopia management if they were to start doing that in their practice?
I think it goes back to what I said originally. Really, this is in our wheelhouse. We know how all of this works. We're comfortable with all the tools. It's just putting in the practice management, the business processes on how you're going to educate your patients. How much are you going to charge? If they lose a contact lens, what's that going to look like? What's your warranty? Educating your staff, because phone calls are going to come in. You want your staff to answer them intelligently. So you want your capture rate to be high.
Right.
So it's taking a whole office approach, education, business processes, pricing, exam protocols, and then flick the switch, and then it becomes seamless. You know exactly what to do when each scenario arises.
So can you think of an instance where myopia management did something for a patient that you didn't expect, or a reaction that you didn't expect? That's a great
question. I think what I didn't expect was like I said, I think our first patient was September 2015. So that's exactly 4 years ago. And I think that patient I saw in August. So 0 change on one eye and -1/4 on the other. I didn't expect, and I think we started them at age 8 or 9. So when they were in their fast progressing age, I did not expect to get that kind of control.
That's awesome.
So
that is awesome.
I guess one thing I should backtrack a little bit on, and a lot of docs will ask me this question, is how do you know when to prescribe MyoVision Kids versus MyoVision Pro? Because that can be a little complicated. So is it okay if I touch on that?
Please do.
So the MyoVision Kids, again, that's the one that controls accommodative lag. And a lot of ODs out there aren't comfortable measuring lag. We did it in school. We may not have done it since. So if you go to Kate Gifford's myopiaprofile.org, she's got a great 3-minute YouTube video on how to do MEM RET. That's where you've got that cards kind of glued to your retinoscope.
Yep.
And also you can use the cross-cylinder method as well. A lot of vision therapy docs use that one. So you're looking for high accommodative lag. So Kate Gifford said anything more than 1, they've got accommodative lag. So you may want to consider giving them that PAL type MyoVision Kids. Kids who spend a ton of time on digital devices, you'd want to use the PAL type design. If they're ESOs love an ad, as you know.
Right.
EXOs aren't crazy about ads. So you have to do a little mini BV workout when you prescribe your glasses. If they're EXO and you give them a 2 ad, there are exceptions, but most likely they're going to be even more EXO. And we also use the MyoVision Kids lens in combination with low dose atropine. So as you know, low dose atropine, depending on the strength you use, is going to take away maybe 2 to 3 diopters of accommodation in kids. And some kids notice that. So if they do, we'll put them in the MyoVision Kids and give them, say, like a 150 or a 2 ad to control that. If they're light sensitive with atropine, we can use MyoVision Kids and make it photochromic.
Right.
So we can help with their light sensitivity and their reduced accommodation if we have them on combination therapy. The MyoVision Pro, and again, that's the peripheral defocus theory. So generally we use that in patients who wore the one that came out in 2007. Kids who spend a lot of time outside, playing soccer, playing sports, they typically do better with the MyoVision Pro versus MyoVision Kids. And your EXOs, again, back to that mini BV workout. If you're an EXO, chances are you don't want to give them an ad. So that's when we would go to the MyoVision Pro. So you need to do you don't need a full VT workup, but if you're going to prescribe the ZEISS lenses, you need to do kind of a mini one and figure out which one you're going to put them in, because they are very different and each have their own kind of niche.
Yeah, and I've watched Kate Gifford's videos. They're excellent and a great resource for just a nice little reminder for some of us who may have been rusty, shall we say, with some of our BV testing. And she breaks it down quite well and makes it really easy to just add into your eye exam. And that's why it takes 16 minutes instead of 15.
Yeah, so I like how she holds like 3 or 4 lenses in one hand and just seamlessly flips them around.
Yeah, I couldn't do that, but that was pretty cool. Yes.
Yes.
It's like a magic trick.
Yeah.
And anything said with an Australian accent sounds better.
I would agree.
It makes the videos that much more fun to watch. What's one thing you wish you had known back in 4 years ago when you were starting out with your myopia management?
I guess how complicated it is and how many options. Like I said before, educating parents about all the different tools is super complicated for them. So we did not have our processes in place. We started with Ortho-K because we had kids coming in and asking if we did Ortho-K, and we didn't at the time.
Right.
And after the 4th or 5th parent asked for it, we said, okay, we're just going to dive in and do it. And then we started adding other tools. So if I were to do it again, I would get all my processes in place and then flick the switch and go live.
Good advice. Is there anything I should have asked you but didn't?
No, I think you've covered it, but you'd be okay if I finished with a story?
If it's another complimentary story about me, yes.
It's not. It's about my business partner and my partner in life, Dr. Tina Goodhew.
I'll let you do it anyway.
Okay. So I guess to kind of sum up, this is an optometry's wheelhouse. Ophthalmology is starting to get into this space. I know some pediatric ophthalmologists in our area that are using low dose atropine, which is great, but that's the only thing they know how to do. They don't know about the other 3 tools in the toolbox. So we have the advantage of knowing absolutely everything. So Dr. Tina, my partner in life and partner in business, she had a family doctor patient a couple months ago. The GP comes in, she's minus 3, 2 daughters, 8 and 10. They're myopic and they're progressing 75 diopter per year. So Tina starts talking about myopia control, atropine, and the GP is like, well, can you send me some literature on atropine? That sounds interesting. So Tina said, yeah, I'll email you some research on that. And then the GP turns to Dr. Tina and says, well, who can you send me who's an expert in myopia control? And Tina basically just pointed at herself and said, you're talking to the expert on myopia control.
Right.
The GP just assumed that ophthalmology would be the expert in this space. Right. And, in disease and atropine, they're very erudite, but as far as myopia control in general, optometry is the expert. So I found that to be a very interesting story that oftentimes, there's other professions that are the experts. We're just kind of generalist. We own this space. I think it's great for the profession. We can give our patients great patient care and help protect the future of their eye health.
I will accept that story, and I thought it was excellent, even though it wasn't about me. Okay. But Tina's awesome, so that's excellent. So yeah, I think we covered most of what we wanted to discuss. That was excellent. I always enjoy talking to you, Jeff. I always learn something new. I don't have a lot of optometry heroes, but if I had to make a list, you were on that list. So thanks very much for being on the podcast. I really appreciate it. And thanks for all your great info about ZEISS and their myopic control lenses.
Well, thanks for the compliments, Glenn. It's great to see you back in the podcast space.
Thanks. I appreciate it. I hope you enjoyed this episode of Eyes Wide Open. Please visit our page at eyecarebusiness.ca for more information and links to today's topics and guests. If you're looking for an online optometric community, send an email to canadianoptometrygroup@gmail.com to join the Canadian Optometry Group. You'll get access to a vibrant online community for Canadian optometrists. Thanks to our sponsor, Canadian Eye Care Business Review. Remember to visit them at eyecarebusiness.ca to stay up to date with the latest eye care news and lots of great resources and articles on topics like practice management, marketing, products, team and leadership, and finances and operations. And we'll see you next time for our next episode of Eyes Wide Open.